Hello and welcome to another edition of our Signal Sleuths, right? We are going to be cracking some EMG cases, more likely just reviewing them. I'm Ken Vitale. I'm a physician in San Diego. I work at the University Hospital and do a lot of EMGs for orthopedics. Come across some interesting cases, well, like this one. So let's get started. We have lower extremity studies. Previous one was upper, and well, once again, we have a smattering of red here, some no responses at superficial perineal sensory, prolonged latency response with low normal amplitude of sural sensory. So what do we got? Not giving you any clinical yet. We're just going with what we have presented. And yeah, is it another case of neuropathy? Well, yeah, it could be. No response to superficial perineal, right? Yeah, well, that's actually kind of a technically hard one. For those of you who are learning EMG and going through this, it can be a little technically difficult to get. It is certainly something you gotta practice at, but you'd be surprised you can find them more often than not. You don't want to just go straight to technically difficult, could not obtain. Yes, once you start to get into older adult age, they are commonly, well, gone, about age of 60, maybe 65, depending on who you talk to. And some people don't even do them as a result. You often don't see much beyond sural sensory in lower extremity studies. Very often when we get studies externally, we see sural, but maybe not superficial perineal or saphenous sensory. So can you really diagnose neuropathy just based on absent superficial perineal sensory studies? And of course, the next question is, well, what's the next step? What do you want? Yeah, and of course, we want motors. So here we are, motor, and again, a kind of sea of red here. Prolonged latency there. These are okay. That one's kind of borderline upper limits of normal there. Very low amplitudes across the board and low conduction velocities. And not kind of mildly low. These are significantly low in the 20s. Which brings us to the question, what are acceptable values, right? What is neuropathy? How do you diagnose it? First of all, you need more than one, not more than one, excuse me, you need three nerves, more than two nerves. You must include the surals when you're talking about neuropathy in the lower extremities. If you go by AANEM, first you check sural. If that's normal, move on. Fibular motor, probably most commonly involved next. Then tibial. If you still are not having issues, but you're clinically suspicious, you go upstairs, right? Get median and ulnar sensory. If you go with Mayo Clinic, same thing. Did I say Mayor? The Mayo Clinic. We have one out here near us in Phoenix, Rochester, Jacksonville. They're all over. Check sorrels if they're normal, move on, same thing. If they're young and less than 55, you go to medial plantar sensory. Otherwise, it's probably going to be, well, abnormal or you got very thickened skin by that time and you won't even be able to get a response. That would be technically difficult. Now, what about these sorrels, right? There are some studies that say anyone above the age of 60, never mind superficial perineal sensory, your sorrels might be absent. Medial plantar also very likely to be absent. So can you really diagnose this on sural sensories? I say if it's well done, you should still see it, and it should at least have some amplitude, about 3 microvolts. Which brings us nicely to how do we diagnose neuropathy, right? What are the criteria? First of all, demyelinating has to be, well, moving slow, less than 70% of the lower limit of normal conduction velocity. That means you got to get underneath the 30s in the lower extremities, and our patient had that. If there is already low amplitude present, you got to bring that threshold down even lower, less than 50. Contrast that to axonal neuropathy. You have to have at least 70% of normal, the exact opposite here. So you got to crack the 30s, get into that area. Our patient actually had some values that were below, so that would be axonal, and that'll be important a little later on in the case. Latency cannot be more than 125% of the upper limit of normal. You can't have horribly prolonged latencies, otherwise that would be demyelinating. Similar things that would basically classify this as demyelinating are things like temporal dispersion and conduction block. You can't have a significant component of that for you to call this a predominantly axonal neuropathy. Now, this also nicely brings us into some different clues here of neuropathy. What if you have a sudden jump? These are kind of little tips and tricks here. When you're doing nerve conduction studies and you get a sudden increase in your CMAP amplitude with a only minimal increase in your stimulation intensity. Why is that? Well, guess what? You just activated a axon with collateral sprouting, reinnervation changes, and suddenly you get a much larger catchment of muscle fibers that are innervated by that motor unit, and boom, your CMAP goes way up. What's another one? This is a neat one that I picked up. Tall F waves, right? Once you're hitting your F waves and you just happen to fire that one that has the reinnervation, suddenly you get a nice tall F wave. That's another sign of neuropathy. I get that here and there. Sometimes it's such bad neuropathy that there's just poor responses, not very reliable response. There's a lot of dropout. Sometimes you get one, sometimes you don't. So you got to just keep on stimulating, and eventually you can't just stimulate well, extensively. You just gotta move on. But if you happen to catch that, good clue of neuropathy. Conversely, how about some pitfalls? What are some things that happen? The big one with neuropathy is having a cool limb. We talked about this in the first case. If you have a cool limb, right, ion channels stay open longer, increases your amplitude, so you're going to miss a potential axonal neuropathy. Similarly, it can prolong the latency so you can get a false positive of a demyelinating neuropathy, both things you don't want. So warm the limbs. So back to our case. What are we missing, right? Well, of course, F waves. I also threw an H reflex. We'll talk about it in a minute, why we did that when the clinicals come in. And yeah, once again, really no appreciable response. This one, we did get one pretty significantly prolonged. H reflex, I would call those, well, more prolonged than we often get when we're looking at S1 radiculopathy. So these are all corroborating or concurrent with our thought of neuropathy. And lastly, EMG. This is kind of a meh EMG. We got some neurogenic changes, increased amplitude, signs of reinnervation, so axonal type processes. And yes, I would generally categorize this as being more distal than proximal. No, didn't go into extensive other muscles, and this is something that we talk about in terms of what we could have done better here, and we'll get to that. Now, what else could we check? This is something that we have to, well, bring in some of the clinicals here, but you could say, well, if the superficial perineals are out, maybe common perineal or fibular. Maybe they're not doing so well, and maybe there's a fibular neuropathy on top of all this. How could we check for that? Well, you could do some left-right comparisons. Sometimes this is not the most valuable table, but it does churn out in a lot of software. Here, right, great, we can tolerate up to 50%, but greater than 50% amplitude side-to-side difference is often considered significant. There's one right there, 62%. Uh-oh, there's a fibular neuropathy, right? Well, no, these are horribly low amplitudes. That is really hard to, that's a tough sell right there, 62%, and here 50% borderline. Yeah, but you're only generating 0.2 and 0.4 millivolts of amplitude. Those are orders of magnitude lower than we'd like to be confident in that diagnosis. But again, another teaching point, often look at side-to-side differences. Here, again, sorry, fail. I was not able to download these and copy these in for the presentation here. Sorry, but we don't have. And so how would we diagnose this? Well, I'll give it to you. Yeah, it's neuropathy, and a pretty bad neuropathy, I would say. Axonal, yes. Demyelinating, yeah, but I'd say axonal is certainly the predominant feature. Sensory, yes, but also motor. Now, right, this is the whole point here. Why are we doing this? What do we not have yet? We don't have the clinicals. And well, I was saving it because I just wanted to. That's what makes these cases interesting. What the heck is going on here? Well, here we go. This is a guy that had plantar fasciitis, and he had bad plantar fasciitis. Oh, my feet are a mess. I got horrible plantar fasciitis. Nothing's getting better. I need surgery. And he had, if you know this, a gastroc recession, and that's what this is basically highlighting here. Surgeons go in endoscopically and they just release the gastroc slash myotendinous junction fairly high up to allow more stretch. He had one done in 2020 and the other extremity in 2023. And why was he getting sent for EMG, he was having dorsal foot numbness. My feet are numb. I think it was a surgery. I'm worried about it. Something happened. Let's do an EMG. That was partly the patient pushing for it, but also the referring provider, who was not particularly orthopedically trained or knowledgeable in terms of the surgical procedures. They just heard, oh, you had surgery, your feet are numb. Maybe we should get an EMG and make sure. I get it, but you know what? That does not fit. Now that you know what goes on over here, uh, surgeon makes the incision in the posterior leg. What nerve is back there? Yeah, obviously sural is going to be back there, not the superficial perineal. And sural sensory, even if it was damaged from surgery, it would not give you dorsal foot numbness. When you start talking about surgery and what can happen, sometimes there's direct trauma, but if you think about mechanically what happens after the surgery, you're going to suddenly get a lot more dorsiflexion. That's why the surgeons are doing the surgery, because there's such tight uh, gastroc, Achilles, plantar fascia, that whole continuous embryological tissue, so to speak, all becomes tight and stiff. If you just stretch the plantar fascia without the gastroc stretching, many patients still have plantar fasciitis. And some patients, they just, well, fail therapy, or they don't do therapy. That's the other case. But it may not stop a surgeon from saying, okay, I'll artificially make that ankle suddenly stretch a little more, and maybe your plantar fasciitis will get better. Well, this patient's symptoms didn't get better. But if you're looking for a technical complication after gastroc recession, think sudden traction to the sural nerve. Now, what is going on with the clinicals? I had to ask as well when I was going through this, hey, have you ever had back pain? Yeah, one episode of back pain, but no real sciatica or radiculopathy symptoms. That didn't seem to pan out, but I kind of threw in the H reflex just to layer it on there, even though it didn't really fit with dorsal foot numbness. I just said, you know what, I'm going to appease the referring provider in case they were worried about potential radiculopathy. So this is not radiculopathy. This is not a sural nerve injury. This is neuropathy. And now when we get a little more info here, I would say that's fairly young to have just age-related neuropathy. This patient has myeloproliferative disorder with a component of thrombocythemia, also a 15-year smoker, now quit, but that has been known to cause a neuropathy and an axonal neuropathy as well, and often sensory is involved. So finally, when we have this, it's like, okay, I get it. This all now makes sense. When you actually examine him, didn't include the exam and not including pictures, but gosh, high arches and intrinsic foot atrophy. It's now becoming pretty darn obvious what's going on. And when you really ask him, he said, oh, well, I've been actually having problems with my feet for years. For about 10 years, I started to notice some numbness in my feet, but it was part of the plantar fasciitis. Like, well, was that really part of the plantar fasciitis? And maybe, I don't know, going back in time, if he was unhappy with the appearance of his foot and he thought it was plantar fasciitis, and well, surgeon did the surgery. That is what it is. So, my favorite slide, what could I have done differently? And there's a whole bunch of things I could have done differently here. What would you have done differently? Well, warm the limbs. If you go back to these slides, yeah, I had pretty bad cold limbs again, unfortunately, and yeah, I should have done that. Should we have gone up to the upper extremities here, done radial sensory for a sural radial amplitude ratio? Some people do that. Should I have included median and ulnar sensory? Should I have done a plantar sensory? Maybe that's part of your protocol. Do you do plantars? Should we throw in the lumbar paraspinals on EMG? I would argue I probably should have done proximal muscles, because if you are trying to rule out or rule in or just more accurately diagnose radiculopathy, if you have very proximal muscles positive, that's got to be radiculopathy. It's not going to be peripheral neuropathy. Nice little clinical tips and tricks there, or clinical pearls for EMG. How about the foot muscle EMG? A lot of times that can be positive in normal situations or people who are older adults. But yeah, you could argue that we could have done some distal muscle EMG as well. And then what about this layering in here? Uh, Could you have done perineal motor to the tibialis anterior? If you had such horrible amplitudes at EDB, maybe move it up to tibialis anterior and better check for a segmental reduction across the fibular head if you really wanted to examine that potential etiology. In this case, I didn't think it was applicable. And another one, I didn't do ultrasound. Yeah, that may have been valuable. And well, this is why we have these nice cases to review. What should you do? What shouldn't you do? So I hope to hear from you in the comments. Let me know what you do in this situation, what you should have done, what blood test do you do, or at least recommend if you're not the one doing it to the referring provider in terms of a neuropathy workup. That might be of interest. And I'll leave you with another interesting AI-generated electromyographer doing some detective work. I don't know what's going on there. Kind of a very odd stethoscope wraparound here. And if you go back through this case, there are some other fairly interesting AI-generated pictures there. One of the pictures with the hands actually showed polydactyly, so that was kind of a neat little thing that AI put in there. All right, hope you join me for the next one.